Welcome. Hi, I'm Mikki, and this is Mikkipedia, where I sit down and chat to doctors, professors, athletes, practitioners, and experts in their fields related to health, nutrition, fitness, and well-being. And I'm delighted that you're here. Kia ora everyone, it's Mikki here, and you are listening to Mikkipedia. This week on the podcast, I speak to my friend Dr. Greg Brown, Medical Director at Wellington Hyperbarics, all about hyperbaric oxygen therapy, or HBOT. We discuss the history of HBOT as a therapy for a range of hard-to-treat conditions and why there are so few clinics available here in New Zealand and Australia as well, despite robust research on its effectiveness internationally, particularly actually in wound healing. Dr. Brown details out the mechanisms behind how HBOT works, the frequency and duration of sessions that they use at Wellington Hyperbarics, and how it is used for conditions such as traumatic brain injury, chronic fatigue, and long COVID. Greg is obviously passionate about this area, and he's always been really interested in nutritional and environmental medicine, and it was great to be able to have a conversation with him about his current role as the medical director of this, and he is a wealth of information. So I really think you're going to get a lot from this podcast. And for those of you unfamiliar with Greg, Dr. Greg Brown is an experienced medical practitioner with a background in general practice, military medicine, travel medicine, and nutritional and environmental medicine. Greg retired from the Royal New Zealand Navy in early 2020 with the rank of Surgeon Lieutenant Commander, having spent a number of years as the Principal Medical Advisor for the operational headquarters of the New Zealand Defence Force. Greg has led the medical support on overseas trips with 2 New Zealand Prime Ministers and has deployed to the Indian Ocean on counter-narcotic operations. He has a broad base of knowledge with experience in medical systems, design and clinical governance. And in fact, both Greg and I were 2 of the founding members of the Ancestral Health Society of New Zealand, and we met back in 2014. Today, Greg's role is to oversee all clinical aspects of the Wellington Hyperbarics unit, ensuring that patients are screened for suitability of the therapy and that an individualised treatment program is constructed for each person. So I've put a link as to where you can find Dr. Greg Brown and the Wellington Hyperbarics team. So if you are interested in this type of therapy or just want to know more, you can absolutely touch base with him there, and he's pretty solid about getting back to you. Before we crack on into the interview, I would just like to remind you the best way to support the podcast is to subscribe on your favourite podcast platform and leave us a 5-star review, because this helps increase the awareness to Mikkipedia and the information and knowledge that I'm privileged to talk to my guests about. That would be amazing. So thank you so much for that. For now though, please enjoy this interview that I had with Dr. Greg Brown. Dr. Greg Brown, thank you so much for taking the time to speak to me this morning. Obviously, we've known each other for a number of years, although not quite, haven't over recent years been able to come together and sort of share the same space and ideas, which is the unfortunate reality of COVID and life and etc. And today, of course, we're talking about your work in hyperbaric oxygen treatment. But of course, you've got quite an extensive background in medicine and in other areas. So can you just sort of introduce yourself and tell people who you are, what you do? Let's start there.
Sure thing, Mikki. Well, it's lovely to talk to you again. As you say, we've known each other for probably, it must be around about 10 years, I would guess, somewhere around then. And I guess that means that we're both getting old, right? But I've been I've been a doctor for 16 years. I qualified from the University of Sheffield in the UK in 2005, and I then trained as a GP in the UK before coming to New Zealand in 2011. And at that point, my career sort of took a left turn into, I guess, slightly less conventional territory. And I joined for a start, I joined the New Zealand Defence Force initially as a civilian medical officer, and then later spent some time in uniform in the Royal New Zealand Navy. So I got to do some pretty fun stuff with that, deploying to see counter narcotics in the Middle East and accompanying a couple of New Zealand prime ministers on a couple of trips and various other things. And around about that time also really took a deep dive into the nutrition and wellness space, which is how, of course, you and I originally connected.
Yeah, and Greg, I'm interested actually because, of course, you have, as you've just said, spent time in Defence Force and in uniform. Were you able to sort of share what you knew about nutrition and wellness in that capacity in your work there, or did you have to keep it quite conventional?
No, I was able to do some stuff there. Made myself marginally unpopular in the early days. Back if we step back to maybe 2012, 2013. Low carbohydrate nutrition was relatively controversial, wasn't it? And I remember sitting there with the results of a patient whose HbA1c had gone down and their lipid profile had improved and they'd lost a bunch of weight. And I had a colleague telling me, "You're doing dangerous things. This guy's going to have a heart attack." And I respectfully differed. And then, of course, you and I were able to make a little bit of progress with that study that your unit at AUT did within the Navy, which I think was around about 2014, which did result in some changes to the nutritional policies of NZDF. But certainly at an individual patient level, treated a bunch of people, used the Whole30 quite a lot.
Yes.
And because I had the luxury of long appointments and the ability to see people again and again and do as many blood tests as I liked, I was able to really track what I was doing with those patients quite closely, and was able to convince myself, as I say, back in the day when it was relatively controversial, that everything was going to improve. It wasn't going to deteriorate. Saturated fat wasn't going to kill people. So that was really good. And I think the other aspect of that is that if you give a military person a plan and say, "Hey, look, if you do this, then X, Y, Z is likely to happen, and hey, I could make you deployable again, and they could send you back to Afghanistan. How about that?" They go, "Oh, that's great, Doc, thanks." Because they seem to, because they loved all that. So that was quite successful, including amongst some very senior officers up to service chief level, and I think partly because of that, that's how we ended up getting the policies changed to a degree. And then on deployment, it was always quite good to do talks to captive audience of ship's company. You've got nothing better to do than sit and listen to me.
But of course, you've moved out of that work now, and today we're talking about hyperbaric oxygen therapy, which prior to us sort of jumping on and hitting record, I was saying to you that the only sort of knowledge in this space that I have, it's so scant. I've been familiar with the concept of it just through a very good friend of mine. Katie Boyd specialises in cancer nutrition and often comes up in some of her treatment plans. And then I heard from our other good friend, Dr. Karen Fanzia, that you are actually running a clinic in Wellington. So I thought, I have to speak to Greg about his work. So this, Greg, will be a very 101 conversation with you. So because I know nothing, and I would probably, I'd put money on the fact that a lot of people listening to this podcast will probably be in a similar situation. So before we sort of get into the nuts and bolts, how did you sort of come to this place where you are now working closely with this hyperbaric oxygen therapy?
Yeah, life takes some interesting twists and turns, doesn't it? And I guess from a 101 perspective, that suits me perfectly because I'm a GP, I'm a specialist generalist. You know, I'm not an academic. I don't have a research paper to my name. So for me, it's all about operationalising hyperbarics and rolling it out to as many people as possible. So I guess I would say this was, you know, right place at the right time. So I was approached by a businessman that I know locally here in the Wellington region, who was after a bit of a legacy project, and he'd been introduced to this idea by some contacts of his who were, you know, seeking to raise some venture capital to get hyperbarics into New Zealand. And he thought, well, actually, why don't I just use my own money and do this? And he asked me to look into it, and if I was interested to come on board as his medical director. And I think, you know, much like probably most doctors certainly in this country, and probably elsewhere, my knowledge of hyperbaric medicine was really limited to exposure adjacent to that with dive medicine, you know, and dive
Yes.
injuries, and I think that's probably what most people associate hyperbarics with. Divers come up with the bends; they need to be repressurized to sometimes quite considerable pressures, and then decompressed slowly to do that. And, you know, to basically state it in a nutshell, it turns out that hyperbarics is much broader in application than that, and is probably the most exciting thing I've come across in my career to date. So in terms of what it is, essentially, I mean, hyperbarics is a dual drug therapy. Okay, if you want to conceptualize it like that, you've got two elements: you've got pressure and you've got oxygen. And the way that it is generally delivered in a medical setting is in a hard shell chamber that's capable of achieving pressures of absolute minimum of 1.5 atmospheres, so 1.5 times atmospheric pressure. But most of the magic happens around about 2 or thereabouts. So that would be the equivalent to like a 10-meter dive in terms of the pressure that's exerted on the body. Okay. And then high flow oxygen is delivered while in a hard shell chamber, and there are, you know, different protocols around how that's done, and we could potentially get into some of that because it's relevant to what hyperbarics actually does. And people are given oxygen under pressure for usually around about an hour and a half. And that's repeated on a daily basis, usually weekdays, more for the convenience of the clinician than the patient. But it's repeated weekdays for often for several weeks.
Okay, and how big is the chamber, Greg? Is it something like the size of an MRI machine, or is it like a small room? Like, what does that look like?
Yeah, so for us, small room would probably be the best analogy. There are lots of different sorts. There are single place, monoplace chambers which you generally lie in, and then there are multi-place with seats, and they can be, in some of the international centres, they can be huge. You know, lots and lots of people with an attendant in the chamber. We have 2 in operation at our facility just north of Wellington. One has got 5 seats. The other has 2, and there's plenty of space to kind of move around within that chamber. Took my family in once, and my son decided that he quite fancied doing a few push-ups in the chamber to see if it could improve his rep range, and so there was room enough for a lanky 16-year-old to drop down and pump out a few push-ups.
Oh, nice. So, Greg, with regards to your original sort of the proposition that was presented to you, what was it about the HBOT that interested your business partner or the investor? So what was it about it that he was like, oh, this actually sounds like something I want to get behind?
It actually works. It's an effective modality for a bunch of conditions that conventional medicine really struggles to manage well. So we're talking about things like dementia and cognitive decline. and we're talking about improving stroke outcomes, talking about improving symptoms of traumatic brain injury. So there's a bunch of things that I think we don't particularly do well in medicine, and really this is a missing modality from the landscape here. And I mean, if you look at any large hospital that you've heard of in the United States, they will have a hyperbaric medicine unit. Okay, and the model has historically been hospital based. Large chambers doing high pressures, and then on the other end of the scale, there's people with canvas bags that do what's referred to as mild HBOT, where they might get to 1.2, 1.3 atmospheres. That sort of Goldilocks zone in the middle, where you're treating people to 1.5 to 2, is something that our proposition, and I guess the trail that we're trying to blaze here, can be done at scale in the community by generalist physicians like myself. You don't need to be a hospital grade thing costing $8 million doing 4 atmospheres. You can do it safely in that 1.5 to 2 range, and benefit lots and lots of people. So that really was the driver, something that's essentially, non-pharmaceutical, right? And that's probably why it's not really got anywhere, because none of, in terms of the model of how medicine traditionally has worked, and seems to be getting worse in that regard, nobody really benefits apart from the patients.
Yeah, it's so interesting, because as I was just doing a bit of background research for our discussion, I did come across several clinical trials looking at HBOT, which you've just called it, which is so much better than HBOT. I mean, hello. And it appears that, as you said, in Europe and over here in the States, there's, it's not standard therapy, but it absolutely is an option. And someone I was listening to is currently doing his PhD, looking at the different pressures that are used in the chambers and which ones might have a more beneficial outcome, depending on the dose and frequency and things like that as well. And I do want to ask you about that. But first, can I ask, Greg, what is the mechanism? What is happening that is helping improve a number of these health outcomes that we're seeing in the literature, and of course you're seeing in the clinic, and as you mentioned, with deep sea diving and stuff like that?
Yeah, so there is the basic upfront mechanism of increased oxygenation. So by giving oxygen under pressure, you're invoking one of the gas laws, and you're invoking Henry's law. So you're effectively dissolving much more oxygen, in this case, into blood plasma, right? So in addition to getting your hemoglobin to saturation point, you're also dissolving oxygen into the plasma. So if somebody is suffering from a wound, for example, due to poor circulation, and fundamentally, hyperbarics heals wounds, right, whether on the inside or the outside. But if we're looking at a visible wound, you're going to be able to get oxygen to that area and improve wound healing in the short term, just because of that one basic mechanism. But it actually goes much deeper than that, because there are 3 other main things that are happening. Okay, so the way that hyperbarics has evolved, and a lot of this is driven by a large research group in Tel Aviv, Israel, led by a chap called Professor Shai Efrati. What they have figured out is that if you cycle people on and off the oxygen, which we do every 20 minutes, so 20 minutes on, 5 minutes off, you actually trick the body into thinking that it's in a state of hypoxia, which it is in a relative sense, right? You've been given, in our case, 20 litres of oxygen for 20 minutes through a mask with a reservoir bag on, and then you get them to take the mask off and breathe the chamber air, which is usually at that point sitting at around 22-23%. So it's not quite room air, just because there's oxygen blowing around. But that then causes the release of the most potent mechanisms that the body has for healing itself. And there are some technical mechanisms around that. There's something called hypoxia-induced factor, and then there's a cascade of things that happen as a result of that. and much of which is, beyond my scope as a simple GP, but I understand it enough to be doing this. The first thing that happens with that is you get vascular endothelial growth factor released, VEGF, which is reasonably well known in the medical community. It's a target of drugs for various reasons. But what VEGF does is it causes angiogenesis, growth of new blood vessels. So let's take the wound as a as a continued example. If you've got arterial insufficiency and that's why you've got an ulcer, you're going to get some oxygen through straight away because we're dissolving it in the plasma. But also at that site, you're going to get the stimulation of new vessel growth to bypass that blockage. And that then becomes a permanent change, right? The vessels are there and they stay there. So that occurs for a wound, but it also occurs places like the brain, with obvious implications for any condition that has disordered blood flow as a mechanism or a consequence. So that's point one, angiogenesis. The second thing that it does over time, and it takes 20 or 30 sessions before this starts to kick in, and then it increases up to sort of 60 sessions and beyond, is the release of larger quantities of circulating stem cells. So that's very well established now that after sort of 30 sessions or thereabouts, you've got 8 times the number of stem cells without the need to harvest and reintroduce your stem cells. Your body is just generating that in response to the hypoxia. So
and how many sessions did you say that would happen?
That usually starts to happen around sort of 20 to 30.
Yeah.
So the studies that have been done, I mean, there was a good study actually that was done that showed that it was essentially by about session 30, you were generating large quantities, and then that effect sort of then increased through to about 60 and then persisted beyond that. So that's the kind of range. So really time consuming to get to that point, but that's the result that it has. The third mechanism gets quite interesting because we're then into the epigenetic realm. Okay, so I'm sure your audience will be well familiar with epigenetics, but obviously the concept that's sitting above the raw genetic code, you can turn on and off genes with various purposes. Now the great thing about hyperbarics is that it does so with the effect of reducing inflammation. So the oxygen and the pressure actually seem to do two different things in this regard. One decreases pro-inflammatory gene expression. The other increases anti-inflammatory gene expression. So you've got this kind of double-headed thing going on. How many conditions of modernity involve inflammation, right? So the breadth of that is then huge.
Yeah. So Greg, one of the first things actually that I want to ask you about is that relative hypo environment. So you mentioned that at the start, that because you're given so much oxygen, that to take it away and get back to what would be considered normal. And what is the normal oxygen saturation? I mean, I feel like I should know this. I feel a bit dumb.
So room air is 21%.
Okay, 21%. And so to go from that, is it close to 100% to?
We definitely don't claim that. I think to do 100% oxygen, you pretty much need to ventilate somebody. But the masks that we use, we're certainly getting into 80-odd%, potentially as much as 90. But it depends on a whole bunch of things: how fast somebody's breathing, how well the mask fits, and we know from other environments that masks are not all they're touted to be. So you've got a great sort of variety of how much people are actually inspiring, but the main thing is you've got 20 liters of oxygen. It's way higher than normal, and then you're cutting down from sort of at least 80-odd% down to 20 odd.
Yeah, crazy. And so you're getting these changes in the angiogenesis. So you're getting increased blood capillaries, and so increased blood flow to areas that would otherwise not have it. Does this mean that sort of conditions like neuropathy that people get in type 2 diabetes, where it ends up with that they have like amputations and things like that something like HBOT could be a therapeutic measure if anyone was at that stage or beginning that stage? Is there research around that, or does the mechanism support something like that?
Yeah, I mean, there is some research around that. There's the on that score. It's a little bit weaker, I guess, than some of the research elsewhere. So, I mean, there was a Cochrane review that was done in 2015 that I think it was 2015 that said essentially that with diabetic foot ulcers particularly, which then will lead to amputations potentially, that it did significantly improve the ulcers healed in the short term, but that the long term was kind of unestablished, and the usual thing that you get in any paper which says more research is needed. So yeah. Absolutely. I mean, people with neuropathies and with chronic pain syndromes and things like that tend to improve quite quickly. We've had some patients that have done well in that regard. Diabetic ulcers and prevention of amputations, and also actually things like chronic osteomyelitis that often goes along with it. That is a well-established indication elsewhere in the world, and in a very real sense, people in New Zealand are losing digits and limbs for lack of hyperbaric oxygen therapy, I believe.
Yeah, so interesting. And then, of course, you mentioned the changes in the epigenetic changes, and that's something which I'm familiar with in terms of sort of nutritional inputs that can help with that occurring. And I think it's really exciting to imagine that something like HBOT could have a similar effect on our anti-inflammatory genes and our antioxidant genes and things like that.
Yeah, it's pretty wild, isn't it? I mean, the breadth of conditions that could be helpful for is considerable, because that is an awful lot of the diseases of modernity. So whether you're talking about neuroinflammation or anything else, you've got you've got a lot of conditions that would be relevant to. Whether it's musculoskeletal or neurological, cardiological. I mean, we've done some of all of that.
Yeah, Greg. So now that we've sort of done a little bit of 101 on what the mechanism is, I mean, you mentioned frequency of dose, like how often it might take someone needs to be in there in order to see some of these benefits. So are there particular protocols that you already have in place based on, of course, your understanding of the literature and stuff as to what someone might expect with any particular health condition? So yeah, do we have doses and frequencies already sort of set out where we know that there are some really sort of significant clinical outcomes?
Yeah, we do. I mean, I think we've got a bit of a tension, I guess, between the ideal and what the research is based on, and what people can afford in terms of time and money, right? So most of the research is based on blocks of 40 sessions. So that's 8 weeks worth of coming every weekday.
Yeah.
Depending on the condition, it could be more, it could be less. For how long? So coming for essentially needing to set aside 2 hours a day, because the session lasts for about an hour and 40 by the time you've done the compression decompression cycle at the beginning and end.
And is it important to have those sort of weekday sessions one after the other? Is that is it this cumulative effect? If you did it and then went away on holiday for 2 weeks, would you essentially be would you have lost some of those gains, or how does that work?
I think there does seem to be a cumulative aspect for sure. And if somebody was to do 1 week and then go off for 2 weeks, I think likely as not, some of the longer term mechanisms that we were talking about around things like angiogenesis and stem cell release, that would probably be resetting the clock back to square one. But our experience has been that once people have a few weeks under their belt, it's actually not a problem to go away for a week. And sometimes actually, depending on the scenario, that can be helpful for them, because if you're travelling up from central Wellington, and you're doing that every day for weeks on end, there's a chronic stress element to that might not be particularly helpful depending on the condition that you're dealing with. So we have certainly had 1 or 2 patients that have gone off for a break for a week and a holiday and come back and actually then done even better subsequent to that. So we don't like people coming for less than less than 4 days a week. We think that that's probably starting to get into the realm of resetting each time. But if people are able to do that for a few weeks, with the flexibility of living in the real world, then it's then fine to take breaks.
Yeah, and it's interesting because, of course, you mentioned that angiogenesis, and that once your body sort of produces these, new blood capillaries, they're there now. So that increased blood flow is just a part of it. That's obviously, that isn't dependent on, once they're there, how often you go. So is there a sort of do you expect 6 months, 3 months, 12 months? I suppose it changes, but in things like, for example, concussion or traumatic brain injury, do we have an idea of how long a treatment like this might need to be undertaken for?
Things like traumatic brain injury, you're really looking at 40 to 60 sessions to get results, and it depends. It depends on the severity. It depends on how long ago the injury was sustained. Our belief is, I can't really back this up, but our belief is that if we can get people fairly soon after the injury, we're going to end up needing to give fewer sessions. We are just today, completing a course of 60 with somebody whose brain injury was 10 years prior to coming to us. But that hasn't stopped this person doing incredibly well and improving absolute leaps and bounds. So yeah, bit of a variability. I think with things like TBIs, our hope is that once they've completed the course of treatment and got to where they want to be, they probably don't need us anymore. And that is the absolute ideal, right? I mean, it's a terrible business model, but it's great for patients. For some of the other indications, things like cognitive decline, there's probably the sense of maybe needing to be topped up every so often, but we don't have a clear idea yet on exactly how often that would be, and we're using some of the sort of technologies and trying to use wearables and app-based sort of gamified testing regimes just to try and enable our patients to track themselves, when they're not coming to us, so that they could maybe see early that something was declining again and to come back for more treatment.
Yeah, and it's interesting, Greg, because a lot of the conditions that you mentioned obviously are ones which I've thought about in terms of the ketogenic diet, following, we talked about the Whole30, like making dietary change to help improve sort of outcomes. Given your experience and background in that realm, are there other recommendations that you make to sort of work alongside HBOT? And if there are, how well received are they by the patient?
It's very much been on an individual patient basis, to be honest. We're not trying at this stage to be too kind of multimodal. I think we've got enough of a battle on our hands. Trying to get HBOT accepted, and try and deal with some of the the skepticism amongst medical colleagues and that sort of thing. But yes, I mean, individual patients, absolutely. We can sort of stray into that arena quite happily. I don't do blood tests and things like that in the hyperbaric clinic. Sort of decided not to go down that avenue. But as providing advice, around lower carbohydrate and sometimes ketogenic diets, that's definitely something that we do. As you will be well aware, how well that's received and how well that's implemented is incredibly variable, but we try.
Yeah, totally. And you know what? And it's so individual, isn't it? Like, for some people, it's almost that, of course, they're going to follow your advice because, HBOT wouldn't be something that anyone comes to. It's not an easy, or it's not something you can sort of do on a whim, just given, as you've said, about the availability of the resource, the time, the money, the potential stress of it. You would imagine that for some people, of course, they're going to do all these other things to really make the most of something like HBOT. I think that would be really interesting research, actually, looking at that sort of adjunct therapy. Greg, do we know of, like I mentioned, Katie, and I mentioned that she has talked about it in light of cancer. What do we know in that realm?
It's there's some controversies around that. We know very clearly that it's incredibly good as an adjunctive therapy, particularly if somebody's needing radiotherapy. Anybody who's ever, as I have, looked after patients having radiotherapy, particularly things like head and neck radiotherapy. I mean, mucositis is absolute hell on earth. It's a complete nightmare. Having pre-treatment with hyperbarics and then post-treatment really just minimises that tissue damage. For obvious reasons, right? So that's really good. And I guess the question often comes up about the angiogenesis aspects of it, because obviously one of the things that tumours do really well is to generate their own angiogenesis, and indeed some cancer drugs are inhibitors of VEGF. So does hyperbarics have the potential to worsen cancer? Like mechanistically, you'd think that it might. In practice, there's actually no evidence that it does. So we certainly see it as an adjunctive thing that's good for pre and post op. Somebody's going to have a major operation. Good to enhance your wound healing as much as possible. And certainly around radiotherapy, there are some contraindications around some sorts of chemotherapy. And it's my job to obviously screen for that and make sure that we don't treat somebody who shouldn't be treated. But yeah, definitely a role. And again, more research required.
Yeah. And what about in a sort of just overall mental health, depression, anxiety? Is there a role for HBOT in something like that? Someone who has, who is non-responsive to other therapies?
Yep, there are some case reports in the literature of that. Yep. And particularly where you get traumatic brain injury and mental health coexisting, and particularly PTSD. So military personnel would be, to go back to my roots, would be a classic example of that. There's a really excellent movie called Silent Explosions that talks about the use of hyperbarics and other functional medicine modalities in people that are brain injured, whether they be sports people or military, and the mental health aspect of that seems to do very well. There's a case report on Parkinson's where somebody's mental health issues went away with hyperbarics as well. So potential for sure.
Yeah, interesting, because I was just thinking about, there's that question on how SSRIs actually might work, working on the anti-inflammatory basis, and so if this 100%. Can do a similar thing. Yeah.
So I mean,
it's interesting.
It's fascinating, isn't it? And I think just the way that finally the biological depression and neurotransmitter theory has gone out of the window, and been reported in reasonably serious news media over the last sort of couple of months. It's been very interesting to watch that unravel. I mean, I read Irving Kersh's book, The Emperor's New Drugs, probably about 15 years ago as a young doctor, and was quite affected by that, and have tried quite hard to prescribe less and less in that arena. But the inflammatory theory, now, I mean, I've spoken on that in relation to nutrition. Actually, you and I think were at the same conference. I think that was in Wanaka back in the day. The things like the Dunedin, childhood longitudinal study, shows certain interleukins, certain cytokines that are elevated in people who are then at subsequently high risk of depression. Does the reason SSRIs work? Is that because they are anti-inflammatories that cross the blood-brain barrier? We don't know, but we certainly know that HBOT is potently anti-inflammatory and works on the brain. So, I'd love to see more to see more patients for pure mental health reasons. We are seeing some where it's adjacent to their issues. You've often got a TBI and depression and ADHD or whatever.
Yeah, Greg. Now, I saw some research looking at, just from that sort of mechanistic perspective, how it helps with mitochondria and helps with ATP production and in that space. And I just thought that I would mention that just because I have spoken to a number of people about mitochondria on the podcast in various sort of conversations around supplements and protocols, and of course cold water therapy and stuff like that. So is that does it help at that real sort of mitochondrial level as well?
It's not something I've actually particularly done a deep dive into personally, but yeah, there are reasons to suspect that it might. It's probably something I need to look into. I probably need to listen to some more of your back episodes, Mikki.
Well, I'm not going to disagree with that. And actually, okay, so what I would love to just chat briefly about, Greg, is the application in long COVID, in COVID recovery, vaccine injury, in all of this space where, this has been at the forefront of our minds for, 2.5 years now. It's sort of slowly getting, we're moving away from it. But I speak to so many people who say that they have long COVID, and I've seen varying reports as to whether or not long COVID even exists. But what is the application for this with people with this ongoing fatigue that they feel? And I think that's probably a good way to describe it.
Yeah, we're walking into a minefield here, aren't we? And you're right. I mean, some of the earlier studies on long COVID, seem to indicate that the primary risk factors for having long COVID was one, a pre-existing anxiety disorder, and two, not actually having had proven COVID in the first place. So, really, really interesting. And I think particularly where you've got a number of viruses that are implicated in fatigue syndromes that follow the primary infection, and most well known being glandular fever. Something that I somehow managed to get in my late 30s while travelling overseas with the Navy, but that's another story. So certainly a number of people with persisting symptoms. There are technical definitions around that, aren't there? Around sort of 12 weeks after clearing the infection and that sort of thing. And it is being looked at. So there's a couple of studies that have been published. One out of the Israeli group and one out of a British group. And small numbers. We're talking, numbers of 30 odd in each group, but done quite well in terms of some people. People got sham HBOT rather than nothing. Rather than placebo or whatever. So I think that seems to have been conducted quite well, and certainly good clinical outcomes, significant improvements in brain MRI perfusion as we would expect, but particularly the clinical outcomes around neuropsychiatric symptoms, fatigue, attention, executive function, those sorts of things. So long COVID, whatever it is, and that sort of overlap, I would suggest as well with spikeopathy from the vaccine, same mechanism, spike protein landing up where you don't want it to be. We possibly haven't seen the half of it yet. We have treated people in that situation, so I have, I'm going to put myself on the line here a little bit by saying that I've treated people with post-vaccine pericarditis, who've then done extremely well. That would be, I would suggest, around the general anti-inflammatory epigenetic stuff that we've talked about as much as anything else. So long COVID definitely looks promising for hyperbarics, and let's be frank, what else is there? What else are we offering these patients?
Yeah, completely. It's usually time. Just wait it out. You'll get better. Take this vitamin C. That's and of course you see protocols. You see massive lists, and I've written massive lists of this supplement might help. This might help. This medication's apparently supposed to be helpful, but I know that for some it's many months of that sort of suboptimal, real deep fatigue, it seems, actually.
Yeah, absolutely. Yeah. There are obviously some organisations like the FLCCC in America that have actually worked very hard to try and get protocols, both back in the day for early treatment of COVID, but also now recovery protocols for those with persistent COVID post-COVID symptoms and with vaccine injury. And interestingly, their latest version of their protocol actually brought in hyperbarics as a modality there, and they suggested it was actually more the pressure than the oxygen that seemed to do the business. So along with all of the stuff that we're not allowed to prescribe and a bunch of other things, hyperbarics is in there, and it's obviously something that we can do.
Yeah, interesting. Greg, you mentioned we talked about pressure at the start of our conversation, and you mentioned the sweet spot could be 1.5 to 2. And I do know that there are people with tents, that that simulate that HBOT in their houses, but is the pressure high enough to get these kind of benefits, or is it that they'll need to go longer if they're in the tent? Like is it? So do we have good information about that?
Well, I'll put it this way. I mean, if we really thought the tents were effective, we could have got a whole heap of those for the cost of a single 2-seat chamber, right? So, where you're dealing with pressures of 1.2, 1.3, I'd hesitate to say that it doesn't do anything at all. But I think that the evidence base is severely lacking. Over a long period of time, would it potentially do something? I think conceivably, and honestly, if people get better without that, then more power to them, and that's fantastic. I really only care about people getting better, not necessarily why or how. So if people are using them and find it effective, it's probably better than nothing. But we think that really, where you look at the numbers, which are not in my head, so don't ask me. But in terms of the partial pressures of oxygen that you can achieve, it's pretty minimal at 1.2 compared to just sitting on oxygen at air at sea level. Effectively. So is it doing much? I doubt it's doing very much.
Yeah. Do you have athletes come in and have sessions to help with performance?
Well, I mean, very well established, right? I mean, Novak Djokovic has got the same brand of chambers that we've got. As I understand it, he's got one at home and a couple that he travels with. So he travels with a hard shell hyperbaric chamber when he goes overseas, when he's allowed to play. So we've seen as an incidental effect that people that have come in for other things have come back and gone, oh, and by the way, even though my shoulder's a bit niggly, I've still I've been benching more than I ever have done over the last couple of weeks since I started therapy. So, well, isn't that interesting? That's really good.
Yeah, totally.
Yeah, so if the Hurricanes want to come to us, or the All Blacks, that'd be absolutely fantastic. We're in the area.
Totally. And now, Greg, just to finish up on that long COVID / spikopathy conversation, I don't know whether you have this in your head or even if we know this, but what kind of frequency, how often would someone need to sort of do this in order to see improvements? What have you seen in your clinic?
Yeah, we've seen really at least 30 sessions for long COVID. Yeah, it really does take a while, but they seem to get there. We've got a few on the go at the moment.
Yeah. And what is the cost of that, Greg?
Yeah, so the cost of hyperbarics we've sort of pegged to an ACC schedule that's for wounds that almost never gets paid out on, but it comes in at about $300 a session. So I mean, if you're doing 30 sessions, that's kind of like a hernia repair. If you're doing 60, it's more like a new hip. So it's that sort of thing. And at the moment, even though it's just on the back of a really good systematic review that was just published in March in America by a guy called Paul Harch, on the back of this systematic review for traumatic brain injury, it's now accepted for insurance purposes in the States. It is not currently accepted by either ACC or insurance providers in New Zealand. That really should change going forward, but at the moment, it is essentially for people who can afford to pay for it, and that's a bit of a tragedy.
And what does it take to change at that sort of higher level? Other than obviously very good peer reviews, but let's face it, we've both been involved in submissions to Ministry of Health on things nutrition related, and they've been just, chucked out. No one's really been interested. So what would it take?
Yeah, what would it take? It's a really good question, isn't it? the DHBs haven't invested in this. There's a chamber in Devonport, my old stomping ground next to the naval base there, that is very underused. There's one in Christchurch that sometimes sees some patients. There's one other GP in Mapua who is doing similar work. Good guy called Tim Ewer, who will be known to many.
Oh yes.
At the kind of national level, there are so many bigger fish to fry at the moment that I think it's going to be very difficult. I mean, the reality is that, if we could see enough people, there are 36,000 TBIs in New Zealand every year because of largely our sporting culture and our terrible roads. So how many of those could we get off ACC weekly comp and back into the workplace? Well, on the basis of the experience that we've had, quite a few actually, and I guess that's the long game. We can function and survive without them, but it would be really nice if they came to the party eventually. I think what it's going to take in the medium term is going to be for one or two of the ACC case managers who've got quite a lot of discretion over what they fund to agree to pay for a course of treatment for selected patients, and that the results of that will then speak for themselves, and maybe we can get some traction from the ground up that way.
Yeah, that would be awesome. And so you just mentioned Christchurch, Nelson, obviously Wellington and Auckland. Are they the major places that you know of, or clinics that are offering this kind of treatment?
I mean the Christchurch and Auckland ones are DHB, so I've only ever known of one patient that I've seen who's had HBOT under the DHB, so Tim in Nelson's sort of really busy with I think lots of autism. We've got a satellite clinic that's setting up in Nelson as well, so we've got a mono place down there, hoping for the same in Auckland and Palmerston North. We'll have a 2-seat in there fairly soon, and then looking at Tauranga as well.
Awesome. Did you just say autism as well down in Nelson?
Yeah.
Is that?
Yeah.
Yeah. So, what about things like epilepsy? Greg, do you think there's application there? I don't know. There's so much crossover between what's good for the brain in terms of different conditions. With regards to the ketogenic diet, I wonder whether the same is true of the HBOT treatment. Yeah,
I mean, we're dealing essentially with pushing the on switch for the body's own healing and regenerative processes, and that's beyond adjusting pressures and things like that for different patients depending on response. The mechanism is general, it's universal. We're not micromanaging the effect of that. We're simply saying to the body, hey, go off and heal yourself. So is it hence me saying that it's so broad that it's very difficult. You cannot remotely present this as a panacea for absolutely everything. But as far as generalizable mechanisms of inducing the body to heal itself, it's up there.
Yeah. No, I think it's super exciting, Greg, and really good to be able to have just even this really basic conversation about the broad mechanisms with which it works, the people that you've seen or conditions that you've seen, and I think at least if anyone out there is listening and this resonates with them and something that they're experiencing, it's another option for them, maybe, which would be great. Yeah. So Greg, how can people get in touch with you and your clinic?
Okay, so we've got the domain hbot.kiwi. So jump onto there. There's quite a few resources on there. Links to research, some downloadable booklets on specific conditions. One or two talks that I've done in the past that's on there. There's one there on aging that got quite a lot of views. So yeah, have a look at hbot.kiwi and you can contact me through there.
That is awesome. Greg, thanks so much for your time this morning. Really appreciate it.
Absolute pleasure talking to you again, Mikki. Thanks very much for the invite.
All right, team. Hopefully you enjoyed that interview as I did. And look, Greg talked about a few different clinics that are available here in New Zealand. And if you do have questions in and around your own sort of do-it-yourself hyperbaric tent, or whether, the effectiveness or utility of it, I totally would recommend touching base with those guys just to see what input or feedback you might get from it. Next week on the podcast, I'm delighted to bring to you a conversation that I had with Alex Middleton, an Australian naturopath and expert in endometriosis, and we do a really good deep dive into that. Until then, you can catch me over on Facebook at Mikki Williden Nutrition, on Instagram and Twitter at Mikki Williden, and my website mikkiwilliden.com, where you can choose to sign up for any one of my meal plans or book a one-on-one consultation with me. All right, team, you have a great week and we'll talk soon. See you later.